हाँ 9:30 इंशाल्लाह। मुझे बताइएगा जी जब हम शुरू कर दें। हेलो,
बिस्मिल्लाह, शुरू कर दें। बिस्मिल्लाह रहमान।
औज़ु बिल्लाहि मिनश शैतानिर रजीम, बिस्मिल्लाहिर रहमानिर रहीम। Can you all hear me, please?
Yes, sir.
Yes, sir.
Yes, sir.
Okay. Now, good to see you and hear from you after a long time, after a gap. So we started with endocrine physiology. We started with the general principles, and then we switched on to systemic endocrinology. We talked about hypothalamus as a neuroendocrine organ. Then we discussed anterior pituitary gland and posterior pituitary gland, and then thyroid gland followed with parathyroid gland. Then we switched on to endocrine pancreas, and we discussed adrenal medulla, and we were touching adrenal cortex, and we did talk about hormones of the adrenal cortex. And then we discussed about the biosynthesis of adrenocortical hormones. Now today we are going to talk about actions of cortisol and of aldosterone, and then adrenocortical function tests. So we were here, just a minute, please. Yes, we were here about the biosynthetic pathway. This was our last slide. And now let us talk about actions of cortisol, which is a glucocorticoid hormone secreted from zona fasciculata, layer of the adrenal cortex.
Excuse me,
right?
sir. Maximize कर देंगे please slide को. Thank you.
Yes, please, sure. Is it all right now?
Ji,
Is
sir.
it okay now?
Ji,
Right.
sir.
Right. So, as you know, adrenocortical hormones, they are steroid hormones. So they have got cytosolic or cytoplasmic receptors, and they synthesize new enzyme and proteins, and they act through new enzymes and new proteins, where cortisol acts as a first, whereas newly synthesized enzyme protein acts as a second messenger for hormonal action. Now, as far as cortisol is concerned, it has got too many functions. So for convenience sake, we can divide them into two categories: metabolic functions and non-metabolic functions. So let us talk about metabolic functions first. Now, in metabolic functions, they are so much elaborate that you may make your life easy if you divide metabolic effects of cortisol into two subheadings, that is hepatic actions and extrahepatic actions. Actions within the liver and actions outside the liver. So let us talk about carbohydrate metabolism first. So actions of cortisol on carbohydrate metabolism, we divide them into two, hepatic and extrahepatic actions. In extrahepatic actions, now this cortisol is an anti-insulin-like hormone. It reduces uptake of glucose by the cells, and it also causes glycogenolysis, that is breakdown of glycogen into glucose. So by reduced uptake of glucose by the cells and by glycogenolysis, it causes rise of blood sugar level or blood glucose level. So it is a hyperglycemic hormone. Whereas within the liver, as far as carbohydrate metabolism is concerned, it stimulates the enzymes responsible for gluconeogenesis. Gluconeogenesis means formation of carbohydrate from non-carbohydrate sources. For example, glucose is formed from amino acids and glycerol. So this is gluconeogenesis in the liver. So within the liver, it stimulates gluconeogenesis. So by actions of increased glycogenolysis, increased gluconeogenesis, reduced glucose uptake, it is a hyperglycemic and diabetogenic hormone. Secondly, effect of cortisol on fat metabolism. Again, we will divide them into two: hepatic actions and extrahepatic actions. Actions within the liver and actions outside the liver. Now, in extrahepatic action for fat metabolism, now the tissue which strikes our mind is adipose tissue. So it mobilizes adipose tissue by stimulating enzyme HSL, hormone sensitive lipase, to convert triglyceride into free fatty acids and glycerol. Whereas within the liver, this liberated free fatty acid in the liver cells, now it enters into beta oxidation pathway to form ketone bodies. So as far as fat metabolism is concerned, in the extrahepatic tissue, it is a lipolytic hormone, whereas within the liver cell, it is a ketogenic hormone, right? And then is protein metabolism. Again, we divide its action into two: hepatic actions and extrahepatic actions. Extrahepatic tissue related with protein metabolism is the muscles. So it mobilizes proteins of the muscles and converts them into amino acids. So it is a protein catabolic hormone as far as outside the liver muscle is concerned, but within the liver, it increases uptake of amino acids into the liver cells and they are converted to proteins. So that means as far as protein metabolism is concerned, cortisol is a proteolytic enzyme in the muscles and is a protein anabolic hormone within the liver cells. As far as its non-metabolic actions are concerned, remember 4 anti-effects or anti-effects. Anti-anaphylactic. Anti-anaphylactic is, it is a wonder drug against anaphylactic reaction. Say, for example, if OAB blood mismatched blood group transfusion is made and person is going into a state of shock, anaphylaxis, so immediately large doses of cortisol or steroids or hydrocortisone infusions are given to the patients because it suppresses antibodies formation and it suppresses antibodies release. So, but it is not a suitable drug to be used for a long period of time because it would lead to suppression of antibodies or immune suppression. But it acts as a wonder drug against anaphylactic reactions. And then it is an anti-allergic hormone. So that means it reduces histamine or histamine-like substances and reduces the features or symptoms of allergic. So that is why if there is a scorpion bite or a snake bite or an insect bite, so immediately some doses of steroids, whether orally are given. And then it is anti-inflammatory, So how does it undo inflammation? We don't know, but it is said that it causes stabilization of lysosomal membrane. It inhibits, it reduces the symptoms of inflammation like redness, swelling, pain, local rise of temperature. So all these features of inflammation, they get reduced, they get mimicked, but it does not cure the inflammation. And probably this is done because it stabilizes lysosomal membrane. So then it is an anti-stress hormone, whether physical or psychological stress. Now, steroid hormone is raised in the plasma at the time of stressful situations. So we don't know how does it undo stress, but probably because of physical stress, it mobilizes glucose and it causes stabilization of the liposomal membrane. And then is effect of cortisol on the lymphoid tissue and thymus. Its prolonged use causes atrophy of the lymphoid tissue and the thymus. And by doing so, lymphocytes count, white blood cells, lymphocytes, they are reduced in the plasma. Eosinopenia or eosinophil counts, they are also reduced. Then is effect of cortisol on erythropoietin sensitive, EPS, or erythropoietin sensitive stem cells of the bone marrow. it stimulates EPS cells of the bone marrow and it increases RBCs. So that is, it leads to erythrocytosis, and then it increases counts of platelets and it increases polymorphonuclear leukocytes or the neutrophils. So neutrophil, that is why a patient of classical Cushing syndrome is characterized with a peculiar blood cellular picture of lymphocytopenia, eosinopenia, anemia, thrombocytopenia, and neutropenia. And then is its effect on gastric HCl producing cell. It stimulates peptic cells of the stomach and it increases HCl, and this HCl increased leads to gastric acidity or flatulence. It can, and then is its effect on the wound healing. Now it suppresses fibroblasts. Fibroblasts are the wound repair cells. Fibroblasts are wound repair cells. So it suppresses fibroblasts and it delays the wound healing. So that is why this is a contraindicated hormone or a drug in fulminant pulmonary tuberculosis and in advanced pulmonary tuberculosis and in cases of peptic ulcer. It does not cause peptic ulcer. Peptic ulcer now, according to 2007 discovery, it is due to Helicobacter pylori like bacteria, but it perpetuates, it accentuates, it increases already existing peptic ulcer. So then is effect of cortisol on the central nervous system. So depending on the dose, depending on the duration of the treatment, and depending upon sensitivity of the patient, it may lead to any symptom from euphoria, that is feeling of well-being, up till insanity. So its prolonged use is a famous known steroid psychosis. Steroid psychosis in some patients may occur, right? So these are the various metabolic and non-metabolic actions.
Sir, sorry to interrupt. Sir, can you please explain the steroids psychosis again?
Now, it may lead to steroid psychosis depending on the dose of the steroid, duration of the steroid, and sensitivity of the patients. Now, from euphoria up till insanity, any grade would appear in different sensitive, may appear in different sensitive patients. So look at here, the picture, typical effects of cortisol on the white blood cells and red blood cells in human. Look at the total leukocytes, polymorphonuclear leukocytes. Total leukocytes, are slightly increased. Polymorphonuclear leukocytes are increased. Lymphocytes are decreased. Eosinophils are decreased. Basophils are decreased. And monocytes, they are increased. And red blood cells are slightly increased as well. So that would mean a patient of Addison's disease, which is adrenocortical insufficiency, is characterized with a peculiar blood cellular picture of lymphocytosis, like eosinophilia, erythrocytosis, increased in platelets, neutrophilia, right? So that would mean, so this is physiology, but you can convert it into pathophysiology of the blood cellular picture in case of Cushing syndrome or in cases of adrenocortical insufficiency or Addison's disease. Now, the features of the Cushing syndrome or the Cushing disease are shown in this slide. If you can see here, now there are slit-like eyes and there is fish-like mouth and there is red rosy cheeks, thin skin, round face, bull-like neck, pendulous abdomen, easy bruisability of the skin with ecchymosis, thin, rubbery, and soft and stria fibers because of the pendulous belly stretch effects, poor muscle development, and there is poor wound healing. So look at the picture of Nusrat Fateh Ali Khan. Nusrat Fateh Ali Khan died at an early age in his early 50s, and he was suffering from Cushing syndrome. He died of the complications of Cushing syndrome. So Cushing syndrome is now this cortisol and aldosterone, so they are regulated through negative feedback system at hypothalamo-pituitary cortical axis. So rise of cortisol in the plasma through the long limb of negative feedback system inhibits anterior pituitary and inhibit hypothalamic neuron or even the neural cells, like to bring back cortisol back to normal. So it is now regulated by an excess of hypothalamo-pituitary cortical axis through an hormonal interplay by the negative feedback system. And this axis is influenced by the exteroceptors and interoceptors. Exteroceptors like physical and psychological stress, change of temperature, and internal environment is change in homeostasis parameters within the body. Now, there is another hormone secreted by the zona glomerulosa, outermost layer of the adrenal cortex, independent of ACTH, that is aldosterone. Like this is again a steroid hormone. Now, those factors in which aldosterone, sorry.
Sorry to interrupt. मैं काफी देर से डॉक्टर खिजर एंड डॉक्टर जफर से कह रही हूँ प्लीज म्यूट कर लें. We are disturbed. Please mute.
Right.
Thank you.
Look at the effect of aldosterone. Which are the four? Can you see the slide on the full screen?
Yes, sir.
Yes, sir. Okay. Right. Aldosterone. There are four regulatory factors for secretion of aldosterone. They are hyponatremia, that is fall in sodium, hyperkalemia, rise in potassium in the plasma, hypovolemia, that is hemorrhage or sudden hemorrhage, sudden large hemorrhage, or ECF volume reduced, and fall in BP, especially hypotension of hypovolemic in region. Like, please remember there are four potent determining factors for secretion of aldosterone: hyponatremia, hyperkalemia, hypovolemia, and hypotension of hypovolemic in region. Like, and what does aldosterone do? Very easy. It increases sodium in the plasma. It reduces potassium in the plasma, that is increased urinary excretion of potassium. Now restores or increases the ECF volume and increases the blood pressure. But the question is, how does it do it? Look at the slide. Now there are tiny fonts in the slide, but I will go a bit slow. Now dehydration, which means ECF volume reduced, sodium deficiency, which means hyponatremia, would lead to fall in ECF volume, would lead to drop in blood pressure. So these four stimuli will affect on the juxtaglomerular cells located in the afferent arterioles of the kidney to cause secretion of a protein hormone called as renin. So these stimuli also affect the liver cell to secrete an alpha-2 globule protein called as angiotensinogen. So renin affects on its substrates angiotensinogen in the plasma to convert it into angiotensin 1. Angiotensin 1 is biologically inert or inactive. It is rendered to its active form, angiotensin 2, with the help of enzyme, angiotensin converting enzyme. Angiotensin converting enzyme, or ACE enzyme, it is mainly synthesized in the lungs. It is also comes from the kidney, skin, and the other tissues, but mainly from the lungs. So angiotensin 2, after being it's converted into angiotensin 2, as the word indicates, angio means blood vessels. Tensins means constriction, causes tension. So it constricts the arterioles, leading to increased total peripheral resistance, leading to increased diastolic blood pressure. And then angiotensin 2 also affects on the zona glomerulosa layer of the adrenal cortex to cause secretion of aldosterone. So this aldosterone, through the general circulation, it goes to the renal tubules, it stimulates sodium-potassium exchange transport system, sodium-hydrogen counter-transport system, and sodium-ammonium counter-transport system. So that is hydrogen ion, ammonium ion, and potassium is excreted through the urine, and sodium is conserved to 99.2% into the plasma. So when sodium gets absorbed, like it is an osmotically active substance, 92% of osmolarity of the plasma depends on sodium alone. So there is a physical property of sodium that when it goes, it takes with it sodium chloride, bicarbonate, and water ions with it. So reabsorption of sodium is followed with reabsorption of chloride, bicarbonate, and water. So conservation or retention of sodium with water will increase the blood volume, will increase the blood pressure, bring back to normal. So this is how renin-angiotensin aldosterone mechanism through long term of regulation of blood pressure helps in restoration of the blood volume and of the blood pressure. As we have been doing for all the endocrine glands, let us see abnormalities. So let us put this basic knowledge into practical use, clinical physiology of the adrenal cortex. Hypercortism is Cushing syndrome. Aldosteronism could be primary or secondary, and there could be androgenic adrenal hyperplasia or estrogenic adrenal hyperplasia. We talked last time that immediate precursor for estrogen is androgen. So if more androgen are converted to estrogen, it would lead to estrogenic adrenal hyperplasia. And then there is a hypocortism condition, like which is adrenocortical deficiency, is called as Addison's disease. Now look at the plasma electrolyte level and adrenocortical insufficiency, which means Addison's disease, are in primary hyperaldosteronism. Like, look at the normal values. Sodium is 142 milliequivalent per liter, 4.5 milliequivalent per liter is potassium, 105 milliequivalent per liter is chloride, and normal 25 milliequivalent per liter is normal. What will happen to the plasma electrolytes in adrenocortical insufficiency or Addison's disease? So you see, sodium is reduced, potassium is raised, chloride is decreased, and there's no change in bicarbonate concentration. Look at primary hyperaldosteronism, tumor of the zona glomerulosa layer of the adrenal cortex. Sodium will slightly go up, potassium is decreased, like chloride is decreased, and bicarbonate level goes up. So it leads to primary hyperaldosteronism would lead to metabolic alkalosis, whereas Addison's disease would lead to metabolic acidosis. Right. Now, this is the pathophysiology of primary hyperaldosteronism. If there's tumor of the zona glomerulosa layer of the adrenal cortex, that is a condition of primary aldosteronism. It will lead to increased sodium reabsorption and potassium excretion. Potassium excretion would lead to hypokalemia, which would lead to metabolic alkalosis and weakness or paralysis of the muscles. And then sodium reabsorption increased will lead to hypernatremia, which will increase plasma volume, increase circulatory overload, and there will be hypertension, and their renin-angiotensin system will be stressed. And if there are secondary aldosteronism, those conditions of secondary aldosteronism which occur without hypertension may include nephrotic syndrome, cirrhosis of the liver, congestive cardiac failure, and decreased effective plasma volume, like excessive use of diuretics, salt restriction, sudden large hemorrhage, or blood loss. So those conditions of secondary hyperaldosteronism, which are associated with hypertension, include unilateral renal hypertension, malignant hypertension, oral contraceptive-related hypertension, and renin-secreting renal tumors like primary reninism. Similarly, if there are more androgen secreted, so that means if there is a tumor of the zona reticularis, cells of the adrenal cortex, it would lead to androgenic adrenal hyperplasia. The features would depend whether the poor victim is a child or the poor victim is an adult. If the poor victim is a child, it will lead to whether the poor victim is a male or a female. If it is a male child and androgens are excessively raised, it would lead to features of infant Hercules. If the poor victim is a female child and androgens are abnormally raised, it will lead to features of pseudo-hermaphroditism. If the poor victim is a male adult and androgens are abnormally raised, it will lead to exaggerated masculinity. If the poor victim is a female adult and androgens are abnormally raised, it will lead to masculinization of a female. On the similar line, if more androgens are converted to estrogen, it will lead to estrogenic adrenal hyperplasia. If the poor victim is a male child and estrogens are abnormally raised, it will lead to pseudohermaphroditism. If the poor victim is a female child and estrogens are abnormally raised, it will lead to precocious puberty. If the poor victim is a male adult and estrogens are abnormally raised, it will lead to feminization of the male adult. If the poor victim is a female adult and estrogens are abnormally raised, it will lead to exaggerated femininity. Exaggerated femininity means deposition of fat much more than normal over the chest, over the thighs, and other parts of the body. And similarly, as we have been doing for all the endocrine glands, adrenocortical function tests. So plasma ACTH and cortisol will help us whether it is a Cushing disease or Cushing syndrome. If a patient reports to your clinic, he has got abnormally raised ACTH and abnormally raised cortisol and is showing Cushingnoid features, so he is a case of Cushing disease because it is a tumor of the anterior pituitary or ectopic secretion of ACTH. Another patient reports to your clinic, he has got fall in ACTH, but much more rise than normal of cortisol. He is a case of Cushing syndrome, now which is a tumor of the cells of the adrenal cortex. Now, hyperglycemia occurs in hypercortism, and hypoglycemia occurs with adrenocortical insufficiency. And the blood cellular picture, we have just known, now blood cellular picture, that is of white blood cells and red blood cells in adrenocortical insufficiency, and in case of Cushing syndrome, we have just studied it. And if there is no radioimmunoassay or ELISA technique established, now you can ask the patient to collect 24 hours of urine in a clean aseptic receptacle and then estimate 17 hydroxy and then estimate 17 hydroxy.
Dr. Sehresh, please mute करें. Dr. Sehresh.
नहीं फिर भी
Right. Ask the patient to collect 24 hours collection of urine in aseptic receptacle and then estimate it for 17 hydroxy ketosteroid and then compare it with the value of urinary excretion of 17 hydroxysteroid. That will give us some clue to know the endocrinal status of the adrenal medulla. So then there are certain dynamic tests like dexamethasone suppression test. If you think patient is showing a Cushingnoid feature, you can expose him to dexamethasone suppression test. Dexamethasone is given in large doses, say for example at 8 a.m. because cortisol follows the circadian rhythm. So you ask the patient to come at 8 or 9 a.m. and next morning exactly at 8 or 9 a.m. so that the circadian rhythm is not disturbed. So dexamethasone is given in large doses and cortisol is estimated in the plasma. Dexamethasone in normal individual suppresses plasma secretion of cortisol. But if in the next morning at 8 or 9 a.m., his cortisol secretion remains elevated, so that means it is a case of Cushing syndrome. And then if you suspect some patient to be a case of secondary hypocortism, so then you may expose him to his ACH stimulation test. And if cortisol levels start rising in the plasma, so that means he is a case of secondary hypocortism. And similarly, metarapone is a drug which in selective patients reduces levels of ACTH. Rise of ACTH secretion continuation would mean it is an ectopic secretion of ACTH or it is hyperpituitarism. Now, with this, let us move on to gastrointestinal physiology. Any question, please? Right.